Good morning, ladies and gentlemen. Today, my topic is going to be concerning inflammatory bowel disease. I'm going to be briefly describing the two subtypes under this category, and I'll try to make it as easy and interesting as possible. Now, let's get started. What is inflammatory bowel disease? From the name itself, we know that it is an inflammatory process. It's an abnormal mucosal reaction that involves the GI tract, and it usually results in a chronic condition in young women. Now, this category, it's further subdivided into two different types, and that is ulcerative colitis as well as Crohn's disease. Now, how would the doctor, or you as a doctor, how would you diagnose the patient as either type? Is it based on the signs and symptoms, or is it based on what exactly? The distinction is based on the affected sites, the distribution of the affected sites. As you can see in this image, we have the distribution over here for Crohn's disease is going to be discontinuous. It's all over the place. We have an inflammation here, we have an inflammation here, so it's all over the place. Whereas in ulcerative colitis, it just starts in the rectum and then it ascends all the way up. So it always involves the rectum, and we're going to get into the details of these major characteristics that are going to be differentiating two different types of inflammatory bowel disease. Now, let's go to the patient himself. The patient is going to come and is going to tell you, well, I feel like my abdomen is distended. I feel tired very easily. I feel like I'm dehydrated. I feel like I'm losing. I've lost a lot of weight over the last, I don't know, like 3 months or even 5 months. And that would indicate that the weight loss may indicate malabsorption. There is a problem in the GI tract of that patient that is going to interfere with the nutrients and all the vital organic substances that need to be absorbed that is vital for the patients. So that's how they're going to be presenting with malabsorption and weight loss. And you're going to have bloody stools. So it's very important for the doctor to keep that in the differential diagnosis. Whenever the patient comes complaining of these symptoms, you're going to have many on your list, but Crohn's disease should be at the very top of your head, right? So what is Crohn's disease, which is a part of the inflammatory diseases? It may affect any part of the GI tract. You can see in this picture, right? It may involve the cecum, it may involve the transverse colon, all the GI tract. Any part of the GI tract can be affected by Crohn's disease. And it's very important to remember that the most sites that are involved are going to include the terminal ileum, the ileocecal valve. From the name itself, it's going to be between the ileum and the cecum. It's a valve between these two, as well as the cecum itself. Now, the way I like to remember Crohn's disease is that the C reminds me of the 3 C's to keep in mind. And that includes the first C, which is going to be the cobblestone appearance. That's going to be appearing grossly. C for cobblestone. And another C is that there will be creeping fat. Creeping fats. We're going to get into details, but I'm just giving you the 3 C's so you can keep these in mind. The 3 C's. The first one is the creeping fat. The second one is going to be corticosteroids. This is one way in which we can treat Crohn's disease. And then finally, the third C, which is going to be the creeping fats. Creeping fats, cobblestone, as well as corticosteroids. These are the 3 C's that you have to keep in mind instantly whenever you mention or whenever you read Crohn's disease. Now, how would it look grossly? Because there are many modalities that are going to be used in order for you to diagnose that the patient is having Crohn's disease, and that includes colonoscopy or biopsies. And it's very important for you to take biopsies from different parts, because how else would you know if it's continuous or it's discontinuous? So it's very important to do colonoscopy and as well as biopsies from different parts of the GI tract. Now, what you're going to see grossly, you're going to see skip lesions, and these are multiple, separate, sharply delineated areas of the disease. Strictures are going to be common as well as linear snake-like ulcerations. Linear snake-like ulcerations, they're basically just ulcerations that are having the form of a snake, and they're linear, obviously. Now, the cobblestone appearance on the mucosa is just the way it looks, because whenever you look at the cobblestone appearance, you're going to think of a wall with different bricks, right? The wall is made of bricks. And here, it just looks like different bricks on a wall. And this is the concept of the cobblestone appearance in Crohn's disease. So there will always be creeping fat as well. And not always, but in several cases, there will be creeping fat. And the creeping fat is just the mesenteric fat itself getting thickened. Thickened mesenteric fat that extends around the serosal surface, and that is creeping fat. So just remember, Crohn's disease, C, corticosteroids, cobblestone appearance, as well as creeping fats. Now moving on to the microscopic appearance. These two characteristics are not very specialized to Crohn's disease. These two are also seen in ulcerative colitis, because it just indicates that there is an inflammatory process that is going to be disrupting the GI tract. So microscopically, you're going to see cryptitis. The word itself tells you that there is an inflammation of the crypts, as well as crypt abscess. Chronicity features, because we mentioned in the beginning that it is a chronic disease. So you're going to see chronicity features, and that includes distortion of the mucosal architecture. So the organization of the layers, mucosa, the submucosa, the adventitia, the serosa, all of these are not going to be as organized as it is in normal individuals with no inflammation. There will be mucin depletion as well as Paneth cell metaplasia as a response of this inflammatory process. Now, these two last traits are very specialized to Crohn's disease. Non-caseating granulomas as well as transmural inflammation. Now, what do I mean by transmural inflammation? Trans means all. All of the layers are involved in Crohn's disease, whereas in ulcerative colitis, you're going to see it's a different case. Moving on to the gross features, as you can see, we have these two areas that are narrowed, but this area seems normal, right? So it has skipped this area, and this is the concept of colonic segment that has skip lesions. This is an ulceration that is linear and it's shaped like a snake. Linear snake-like ulceration, cobblestone appearance, another picture that shows us the cobblestone appearance. As you can see, the lumen over here, if you're going to compare it to the lumen over here, it's quite narrowed. So this is the lumen of the ileum that is narrowed during the process of the inflammatory process in Crohn's disease. This is the non-caseating granuloma. This is cryptitis. You can see a lot of neutrophils because at the end of the day, it's just an inflammatory process. So all the inflammatory traits are going to be found in these microscopic specimens. Now, what are the complications of Crohn's disease? When the patient comes and he learns that he's having this chronic condition that's going to be lifelong, they want to know, what are the complications? Like, should I come for you for follow-ups every once in a while? Am I more prone to getting certain diseases or even cancer? Or what are the probability of me getting this and that? So it's very important for you to mention the complications that the patient is going to be more prone to. One of the most important ones is malabsorption, because this inflammatory process in the GI tract is going to disrupt the way in which the GI tract is going to be absorbing vital nutrients, vitamins, even supplements that the patient is taking. So it's very important to let the patient know that you're going to be having malabsorption, and that would lead to weight loss. Fistula formation, anal lesions, contags, fissures. Acute complications could be perforation and malignancy. Yes, you do have an increased risk of having adenocarcinoma. This is how you compare a healthy one to Crohn's disease. We said C is going to be cobblestone, corticosteroids, as well as creeping fat. as well as fissures over here and muscle hypertrophy. And we're going to compare it to ulcerative colitis,